All right, so it's been, I think, a couple years since I gave thyroid, and I figured it's probably about time we had an open session. So we'll do thyroid. If we have a chance at the end, we'll do parathyroid. I will mention I'm not going to get into the grossing. However, I have asked the chiefs to schedule a grossing thyroid session like in July or August when the new residents come. So we're not going to talk as in depth about grossing, but that'll come in a very, very shortly soon lecture. All right, so thyroid. We'll talk very briefly about development because I think it's important to understand what goes on in the neck. We'll talk about both non-neoplastic and neoplastic conditions, mostly the tumors, and then a little bit about para at the end if we have time. So follicular cells of the thyroid come from endoderm, which condenses at the base of tongue and the foramen cecum. It migraines down the anterior midline of the neck in the thyroglossal duct, all right, and then it kind of comes out and solidifies into the lobes across the trachea. But because of this midline path of descent, it can leave this pyramidal lobe. It can also leave a persistent thyroglossal duct, right, which can become cystically dilated and become a thyroglossal duct cyst. So there's a lot of travel, which is why we see weird things happening sometimes with thyroid. With parathyroid, those come from the third and fourth pharyngeal pouches. The C cells, which of course reside ultimately in the thyroid, are migratory neural crest cells, but they fuse with the ultimobranchial body apparatus from the pharyngeal pouch system. The pharyngeal pouch system, ultimobranchial body, carries the C cells into the thyroid, and that's where they end up residing. And we'll see the residua of this in a minute. Anomalies of thyroid travel could be ectopia anywhere from where it starts in the base of tongue, all the way down into the anterior mediastinum if it descends too far, right? So it doesn't descend enough, it stays up, it descends too far, it goes down into the mediastinum. Lateral neck ectopia is controversial, but we think we have seen it in very, very rare circumstances. You can get abnormal shapes to the thyroid as seen here, and most oftenly just a pyramidal lobe. In these ectopic sites, however, remember you can get carcinomas, therefore don't ever exclude, a weird ectopic thyroid carcinoma in a site in that embryologic descent. We already mentioned the thyroglossal duct cyst, but this should be restricted to the anterior midline along that duct path. This is a persistent cystically dilated glossal duct lined by squamous or respiratory. In about 75% or so of cases, you do see thyroid tissue in the wall, and again, rarely development of carcinoma. I can add this to the gross manual. Actually, let me make myself a note. But in the thyroglossal duct cyst resections, they often resect the hyoid bone because there could be residual thyroid follicles in the hyoid itself. So if you do see the hyoid come out, it might be nice to submit just a section or two of the central hyoid, the piece that's kind of attached to the duct, to see if there's any thyroid in the hyoid. Otherwise, not a huge deal. Okay, we talked about those ultimobranchial bodies that come from the pharyngeal pouch apparatus. They can persist in the adult thyroid as these so-called solid cell nests, and we will see those on higher power in a minute. But remember, these are the ones that carry the C cells in, so sometimes you also see C cells in association. You can see lymphoepithelial cysts in the thyroid gland, which is kind of a almost branchial cleft cyst type of lesion that may be related, again, either to branchial cleft remnants or dilated solid cell nest, but lymphoepithelial cysts can occur in the thyroid as well as in the lateral neck. Here's a better example of those solid cell nests. So seen on low power, they look blue. Seen on higher power, they're kind of blue and clustered. And the nuclei are not really like PTC. They're elongated and grooved, very squamoid or urothelial. In fact, they stain with squamous markers like P63, P40. So just don't get these confused with microcarcinomas or parathyroid or something else. These are just those developmental remnants. Other things you can see in the thyroid as remnants our intrathyroidal parathyroid tissue, thymic tissue, salivary tissue, cartilage, even skeletal muscle or fat, especially as you can see in this image, skeletal muscle, if you're in the isthmus. Remember, this is again that developmental issue where thyroid's traveling down the neck, it's traveling through the skeletal muscle essentially, and so you can get this admixture of muscle and glandular tissue in the isthmus. And this is especially difficult to evaluate extrathyroidal extension in the isthmus because we can always have this combination of things happening. Just like the prostate, the thyroid does not have a true capsule, so we can't really use capsule as evidence of, you know, where the thyroid ends and begins. We have to sort of use other clues. One other just reminder, in the neck and in the retroperitoneum, we can see brown fat that persists into adulthood. So that's just totally normal, no indication of anything weird. All right, so normal thyroid, I'm sure mostly we remember follicular cells, parafollicular C cells, and then of course a richly vascular stroma, because all of these products need to secrete into the bloodstream because these are endocrine organs. As a reminder, your thyroid follicular cells stain with thyroglobulin, which is cytoplasmic, TTF1 and PAX8, which are nuclear. Your C cells stain for things like calcitonin, as well as other neuroendocrine markers, synapto, chromo, etc. Follicles should, in normal state, be very round with very bland nuclei. Bland nuclei meaning dark, round, small, and regular, okay? Things that can happen in states of hyperplasia include papillary infoldings into large follicular lumina, including these so-called Sanderson's posters, or little pillows, right? A little pillow of cells in this bed of colloid. Of course, that'll become important when we talk about, you know, comparing these nuclei to those of PTC. Parafollicular C cells generally are not visible on H&E. When you can see them, they're generally hyperplastic. You can see them here having granular kind of purple cytoplasm, having stippled or salt and peppery chromatin. They exist either at the periphery of a follicle or in the stroma between follicles. So this is C-cell hyperplasia. We'll talk more about that later, but just remember, if you can see them, they're probably hyperplastic. So sometimes, you know, we get frozens for thyroid, we sometimes get frozens for parathyroid, lymph nodes, etc. So there's one way to tell definitively thyroid tissue, and it's this material that's in the center of the follicle in the colloid. So who remembers what this is?
Maybe Junior wants to comment.
Type it in. Yes, so calcium oxalate crystals. So calcium oxalate crystals are indicative that tissue is thyroid. This on the bottom left is parathyroid that has a pseudofollicular growth pattern. So sometimes this can be confusing. If you don't see calcium oxalate, you have to rely on the cytomorphology of the cells. If you do see calcium oxalate, you can be pretty much sure you're in thyroid. Okay, we're moving on to the pathologies. So just remember that goiter is a term for thyroid enlargement for any reason. It's not specific at all. It doesn't mean anything. So when you see, it doesn't mean anything except this thyroid is big. When you see goiter in a clinical history, just please don't take it for granted, and please look in Epic to see what that actually means, because goiter could be inflammation like Hashimoto's, goiter could be hyperplasia like Graves', goiter could be multiple, you know, benign nodules. Goiter could even be a giant malignancy. So please, please, please don't just assume that it's a benign thing. Normal weight of thyroid is about 50 to 30 grams. Just to keep in mind, anything above that is a goiter. So we usually see them abnormally, right? So pretty much they're all going to be goiters, except in rare circumstances. So why do we see them on our table? So certainly if the patient has a medical disease where the thyroid is diffusely enlarged, it's compressing the trachea, they take it out for symptomatic relief. If the patient has other medical disease like Graves' or Hashimoto's that's refractory to medical treatment, they can take the thyroid out to stabilize thyroid function, administer synthetic thyroid hormone. Certainly nodules, right? An FNA showing an indeterminate nodule, we want to definitively diagnose benign or malignant, and an FNA showing malignant nodule for treatment of cancer. We'll get into this much more later. Starting with the non-neoplastic thyroid, the thyroidities we want to think about are things like just nonspecific inflammation, chronic lymphocytic or Hashimoto's, granulomatous or de Quervain's, fibrosing or Rydell's, palpation thyroiditis, more hyperplastic, less inflammatory conditions, including Graves' and dyshormonogenic goiter. So we're going to play a little game of name that thyroiditis. Hopefully you'll play. If not, it's okay. I'll just answer the questions myself. So this thyroid is characteristic, diffusely involved by this very densely blue lymphoid infiltrate with germinal centers and these very pink compressed follicles in the background. Just as a reminder, what you might see on gross is a multinodular kind of lobulated thyroid that looks very pale in comparison to our normal kind of brownish red thyroid. Yes, Hashimoto's, exactly. So chronic lymphocytic or Hashimoto thyroiditis, nodular, severe chronic inflammation with germinal centers, oncocytic change of thyroid follicles, cytologic atypia even of the follicles in those inflamed areas. So caution, sometimes nodular fibrosis. Okay, next one, very spongy grossly. You can see these septae kind of between the spongy nodules. Again, recapitulated here in histology, there's a thin septum. These follicles can range from being very small to being very large. The very large ones have, oh, there's that Sanderson's pollster that we were seeing on the other slide. A lot of these proliferations into the lumen. So this is
So cute.
Is it inflammatory? Macrofollicular.
Graves.
Graves, exactly. So this thing is diffusely involved by this process. Every single section looks like this. So, you know, Graves doesn't always read the textbook because a lot of the times when we see Graves, it's already been treated. So the histologic features might be somewhat challenging compared to like, oh, I don't see scalloping. Oh, I don't see like very much high cellularity, but these are treated, right? So this is often what treated Graves looks like, is this macrofollicular diffuse thyroid process with proliferation into the lumen. So sometimes in Graves, the other thing you might see is on the bottom right, where it actually is more cellular. The follicles are much smaller packed. There is some inflammation, but any of these can be appearances of Graves depending on how severe the disease is and whether they've received treatment. So methimazole, radioactive iodine, sometimes in radioactive iodine, you get just diffuse scarring of the gland. We don't see this very often, but occasionally we do. I think we had a case not too long ago that was a treated radioiodine case, but usually it looks like one of these two things on the right. So this is Graves. All right, the next one, just a little patch of a patch of inflammation in between the follicles. So I'll give it to you, it's nonspecific. So sometimes we just see random thyroiditis and we just call this patchy lymphocytic thyroiditis, nonspecific thyroiditis. It doesn't have the germinal centers usually. It doesn't have that oncocytic change like Hashimoto's. This is quite frequent, but not really specific. Another type of inflammation we see here. So what's this large cell and these smaller cells?
A giant cell, and I guess these smaller cells I take to be histiocytes then.
Exactly. So foamy histiocytes, the multinucleated giant cell is basically just a conglomerate of foamy histiocytes. And so where is the location of these?
Looks like they're actually within. It looks like they're actually within colloid lake, aren't they?
Exactly. They're kind of in the colloid, and they've kind of broken the interface between this follicle and the stroma. So this is characteristic of palpation thyroiditis, which are these histiocytes and giant cells in the follicle or at the border of the follicle and stroma, thought to be related to actual manual palpation, but you know, who really knows? But this is just palpation thyroiditis. Okay, next one. These big nodules.
Granulomas.
Granulomas, exactly. So now we have more epithelioid histiocytes with elongated nuclei rather than foamy histiocytes. We have more giant cells, and they're not just restricted to the small follicle. They're kind of blowing through the thyroid. And so this is granulomatous or de Quervain's that, generally you can see in like an upper respiratory viral infection setting. Certainly could be something like sarcoid, but you could also see granulomas in a peritumoral setting that is not related to any other underlying disease. So granulomatous thyroiditis. This one is diffusely effaced by this fibrosis and patches of chronic inflammation. And maybe you see some plasma cells and lymphocytes. Anybody?
Or described as having a woody texture on clinical exam.
Yes. Very woody.
That would be
very rock hard.
Or fibrosis.
Yeah, Rydell's.
Yeah, Rydell's or fibrosing thyroiditis. So this is rare, but boy, when you see it, you see it. So this is extensive fibrosis that diffusely effaces the thyroid, extends into the surrounding skeletal muscle. You have chronic inflammation, maybe vasculitis. That inflammation is plasma cell rich. And so some people have suggested that this might be a variant of IgG4 related sclerosing disease, right? So collagenous fibrosis, IgG4 positive plasma cells, vasculitis. So in this case, we might want to do an IgG4 IgG stain to see if there's an increased ratio of IgG4 cells.
Does this process actually threaten the airway?
That's a really good question. I think it can if it becomes severe and severely extends outside of the neck and it becomes sort of stuck on the trachea. So it can be, but it's a pretty rare disease.
Okay.
But yeah, theoretically it can. Like the more things we see that compromise the trachea are actually either invasion of cancers like PTC or anaplastic, or just pushing over of the airways by large unilateral nodules.
Okay.
But yeah. All right, this next one is also quite rare. You can see a nodule here in the center that's quite cellular. And then even the background on the bottom left here is very, very cellular. So you might be thinking, could this be a dominant nodule in like a hyperthyroid state like Graves'? It could be. Sometimes you also start seeing these random endocrine atypias, these sort of randomly enlarged cells. And this patient might actually be very, very young. And so when you see something like this, does anybody know that differential diagnosis of a hyperplastic thyroid state if it's not Hashimoto's? If it's not Graves'? Super rare. This is dyshormonogenic goiter. So this is actually a...
Ben got that in chat.
Nice, Ben. Well done. This is a genetic disease from basically thyroid hormone or thyroid hormone receptor like mutations. This is germline. These kids have these really hypercellular nodules, colloid pore, bizarre nuclear atypia, as I showed you. So it's also pretty rare. Just know it exists because you may see it. Yes. All right, so this is a table of all those things we just talked about, including pathogeneses, etc. Look at it on your own. Okay, now the main part of this are the thyroid nodules. Well done, everyone. Thanks for the discussion, and you're going to get more discussion. Okay, so of course, the first step in a thyroid nodule is workup by ultrasound and fine needle aspiration. So mostly FNAs in this country are directed by ultrasound with adequacy to make the aspirator know that we've gotten enough tissue, because these thyroid nodules can be hard to get, they can be bloody, and so we want to make sure that we have enough tissue. So of course they're aspirated, smeared on a slide. Here's an example. This is an H&E that I think I did in the gross room or something, so it's not really reflective of a true FNA, but just as a reminder. Because I always correlate with the cytologic diagnosis, I'm going to review briefly some cytology here. So remember the Bethesda categories of thyroid FNA, ranging from just completely unsatisfactory to benign, these various indeterminate categories, all the way to malignant. So indeterminate categories being nuclear atypia of undetermined significance, papillary, follicular lesion of undetermined significance, essentially meaning microfollicles, maybe a follicular neoplasm, then true follicular neoplasm, and then this suspicious for malignancy category. So Bethesda system came up with expected rates of malignancy when these nodules get resected. You can see how our actual rates of malignancy compare with our cytologic diagnoses, 1, 2, 3, 4, 5, 6. So increasing risk for cancer with each of these diagnoses. we can really only make, as you know, a diagnosis of papillary, medullary, sometimes anaplastic or poorly differentiated on FNA, but of course a diagnosis of follicular carcinoma cannot be made on FNA because we need that architecture. With a benign diagnosis, a patient really should undergo observation unless they're clinically symptomatic such that they need the thyroid out. With a malignant diagnosis, either total or sometimes lobectomy, depending on if it's a small, low-risk cancer. With an indeterminate diagnosis, we're now going to molecular testing rather than repeat FNA. I'll talk about molecular testing in a second. Just as a reminder, cytologic features of papillary thyroid carcinoma vary cellular with characteristic nuclear features and dense cytoplasm. Medullary often has these plasmacytoid single cells out in the stroma, granular cytoplasm. Sometimes medullary can also have pseudo-inclusions, just so be careful. Follicular neoplasms, right, could be follicular adenoma, could be follicular carcinoma, tend to be cellular with microfollicles and very round gland nuclei. All right, here's that molecular testing. So when you get an indeterminate cytology like an AUS, FLUS, follicular neoplasm, we send these out for molecular. At this institution, we send to Interpace, but these three are all available and they all pretty much do the same thing. So if you get a negative result on an indeterminate cytology, you've basically now bumped this down into an essentially benign category and you can avoid surgery. So even though this wasn't a cytologically benign, this is now a molecularly benign. But what happens if you get a not negative or not benign result? So the risk of malignancy here can range anywhere from 1/4 to almost 100% and is highly dependent on what is actually found by each company. They do messenger RNA profiles, microRNA profiles. They do specific mutations. So if you find a specific mutation like a BRAF or a RET PTC, that's pretty much cancer. If you find a RAS or a PAX8 PPAR gamma, this is still within a follicular neoplasm, which could be benign or malignant. If you find something like RET, that's going to be medullary. And if you find something like TERT or TP53, that could be an indication of an aggressive carcinoma. So don't just take negative and positive at face value. Really investigate what that positive mutation or positive gene expression profile means. So to recap, with a benign result on your gene expression profile on FNA, observation is appropriate. With a positive, suspicious, or indeterminate result, that patient usually is still going to get a diagnostic lobectomy. However, that might change if a cancer-specific mutation is found, like we talked about earlier, versus a non-cancer specific mutation. Does this all make sense? So I've always asked you guys, just carefully read those FNA reports because there's a lot of information buried in there that we don't always think about. And sometimes in the clinical notes, they just say, oh, testing came back positive or testing came back negative. Well, just really look at what that positive means. Okay, so once that nodule comes out, our role is to determine benign from malignant, and certainly if malignant, to provide staging information. When you're grossing or when you're looking at the slides, please look at the FNA diagnosis and the ultrasound findings to sort of correlate size, location, and FNA diagnosis so we know that we're telling them helpful information for that nodule that they are interested in. Of course, we always want to look on low power at the circumscription and encapsulation, at the growth pattern, and the nuclear features. So my general approach to how to kind of consider a nodule, as I said, we're going to do a grossing lecture later on. But we'll talk about the micro here. Oh, the other thing I wanted to mention was I did put a link in the M drive to a lecture I gave at the AAPA, the PA Association meeting, that actually goes a lot more both into the molecular testing and into grossing. So that link is on the M drive if you want to watch it. Just don't put it up on YouTube or whatever, because Corey gave it to me with the kind of assumption that we would just kind of keep it within ourselves. But it's there for you guys to watch if you want. All right, so how to approach a nodule when we see it on the slide. So first of all, this is circumscribed. Yes, you can sort of draw a line around the edge, but unencapsulated, fine. The follicles are small or micro and the nuclei are bland. So knowing me or knowing yourselves, what diagnosis would you give this? Type it in, speak it out. What's your line diagnosis? You probably can't be wrong unless you call it cancer.
Microfollicular adenomatous nodule.
Okay, microfollicular adenomatous nodule. So that's exactly what I would call it. So micro, because the follicles are small. Adenomatous, I'll tell you why adenomatous. And then nodule or neoplasm, exactly. So this usually corresponds to follicular lesion of undetermined significance or follicular neoplasm on FNA. So I like to use my sort of histologic terms that kind of correlate to the FNA terms. And so these may be neoplastic, so adenomas. They may be non-neoplastic, hyperplasias, but we can't really tell on histology, hence adenomatous, or sometimes people say adenomatoid. Okay, the next one is also very well circumscribed, but unencapsulated. But however, the follicles are large or sort of macrofollicular, but the nuclei are still round, bland, and regular. So this one is now a
Acrofollicular adenomatous nodule.
macrofollicular adenomatous nodule. Usually this got an FNA diagnosis, probably of a colloid nodule, because it's colloid rich, right? So the prior one was cell rich, this one is colloid rich. So they call it FLUS versus colloid nodule. We call it macro versus micro, or micro versus macro. So I just want to point out some terms that are out there. So define multinodular goiter, define colloid nodular disease, define nodular hyperplasia. What does this really mean? What does this look like? I'm not entirely sure. So theoretically, multinodular goiter should be an enlarged thyroid that is enlarged by multiple nodules. Colloid nodular disease is probably a thyroid that is enlarged by multiple macrofollicular nodules. Nodular hyperplasia, these are all generic terms that don't really tell you anything about the histology, and there's no good consensus term. As I said, some that are called nodular hyperplasia actually have been shown to be monoclonal neoplasms by like mutations or by X inactivation studies, and some have been shown to be polyclonal, i.e. hyperplastic. Because we cannot tell the difference on histology, again, that's why I call them adenomatous or adenomatoid, multiple macrofollicular adenomatous nodules, solitary macrofollicular adenomatous nodule, solitary micro, multiple micro, right? So I describe what I see rather than trying to assume whether these are hyperplasias, neoplasias, etc. As long as we know they're benign. Does this all make sense? I think this is a much easier way to make a thyroid diagnosis, is just sort of describing what you see rather than trying to assume the pathogenesis of it. Okay, what about an actual follicular adenoma? So I tend to reserve this for a nodule head that has a well-defined capsule, still has bland cytologic features, and of course has the absence of capsular or vascular invasion. If we see a thick capsule, we'll probably want to submit it entirely to exclude any invasion. The morphology of the tumor cells within the capsule can certainly be microfollicular, can be macrofollicular, can be oncocytic or Hürthle. So don't let the morphology of the cells kind of dictate, let the periphery and the capsule dictate. As I'll talk in the Gross lecture next month, I don't always expect you to submit the entire capsule up front, because sometimes the gross evaluation is not as good as the microscopic evaluation. And I would rather go back later to submit more capsule than have you submit 50 blocks up front of something that I didn't really need in the first place. So in this case, it's okay to be conservative with your capsule submission. We can always go back. As a reminder of, an oncocytic or a Hürthle cell adenoma, oncocytes, as you know, are metaplastic changes in various organs, including thyroid, parathyroid, kidney. I would add here even salivary gland, right? These have abundant eosinophilic granular cytoplasm because they're full of mitochondria, large round nuclei with prominent nucleoli, named after Hürthle. But Hürthle didn't actually describe oncocytes. It was thought that he may have actually described C cells. It's thought that Ashkenazi described oncocytes. So it's all screwed up. I don't use the term Hürthle. I always call something oncocytic, but Hürthle is still out there. And in fact, Hürthle cell adenoma, Hürthle cell carcinoma is in the WHO and is thought to actually be somewhat genetically different from other follicular neoplasms like follicular adenoma, follicular carcinoma, because it actually is thought to have more evidence of mitochondrial gene anomalies. So interesting, maybe Hürthle actually is different than follicular cells, but sort of to be determined. Questions, comments? Okay. We'll move on now to the tumors of uncertain or low malignant potential, and then the carcinomas. We have two uncertain malignant potential tumors. The first is HTT, hyalinizing trabecular tumor. This is thought to generally be indolent, but rarely metastasizing, hence tumor rather than adenoma. RET PTC rearrangements, again, very similar to PTC, and in fact is considered by some to be a variant. Just remember that trabecular architecture does not mean HTT, but it can certainly be a suggestion to the diagnosis. This is a circumscribed, usually non-infiltrative tumor that has these trabeculae or cords, right, elongated cords of follicular epithelial cells that have nuclei that tend to be oriented perpendicular to the long axis of the trabeculum, almost palisading, and have very PTC-like nuclei. Grooves, inclusions, nuclear membrane irregularities, more inclusions. So these effectively have PTC nuclei with trabeculae and often hyalinized stroma. The other tumor of low or very, very low malignant potential is NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. We will talk about this in the context of PTC later, but we know sort of now that this is essentially an adenoma with cytologic atypia that formerly used to be called the variant of cancer. All right, so here are our malignancies. So PTC, FTC, poorly diff, undifferenoplastic. We'll talk about medullary, and we'll talk about a couple other very rare tumors briefly. Just as a reminder of the mutations that you can see in that spectrum, follicular adenoma and carcinoma have genetic identity, meaning they all have RAS mutations and or PAX8 PPAR gamma fusions. Let me rephrase that. Not all, but very, very many of them have this genetic profile. Papillary carcinoma has BRAF V600E, RET PTC. Now we can even add things like NTRK. Poorly different anaplastic tends to have things like TP53 mutation or TERT promoter mutation. Medullary carcinoma, of course, of C cells has RET mutations. Remember that both PTC and FTC can transform to poorly diff. PTC, FTC, and poorly diff can transform to anaplastic, but these can all arise de novo. In some cases, we don't know the genetic drivers of cancer, but we're trying to find them all. The two most common that we're going to see, right, are papillary and follicular. The genetics, as I already said, are essentially mutually exclusive, so you should not find these two mutations in the same tumor. PTC tends to spread lymphatically to lymph nodes, follicular hematogenously to things like bone, lung, brain, liver. PTC tends to have very good survival, even with lymph node metastases. FTC, once it's out of the box, has poor survival. Gross appearance of PTC can range from anywhere to cystic, with proliferations into the cyst, to solid, to calcified, usually very white, sometimes so calcific it needs decalcification. Why papillary? Well, because mostly these contain morphologic papillae, so central fibrovascular cores with epithelial cells surrounding the core, here cut longitudinally versus on cross-section. Just as a reminder, this is what it looks like on H&E, longitudinal versus cross-section of a papillum lined by these malignant elongated nuclei. Often PTC has fibrosis. Often it has these sort of cleft-like spaces with elongated follicles or papillae. So remember the morphology of PTC. You can have papillae, but you certainly can also have follicles. You can also have solid areas. So we call it PTC, but remember the actual morphology can be quite varied. We can see a small or an abortive papillum right here. We can see follicles here. We can see these malignant cells clefting through stroma. and we can see a classic psammoma body here, this concentrically lamellated calcification, which is thought to be an infarcted papillary tuft. Nuclear features of PTC are shown here, being enlarged, elongated, grooved, intranuclear pseudoinclusions, overlapping. So-called orphan anti-eyes are basically just clearing of chromatin, where the chromatin marginates to the periphery and looks like this old orphan Annie cartoon. So why do we get these things? It's thought 2 reasons. As I said, the chromatin clearing is just margination to the periphery. However, the other grooves, indentations, and inclusions are thought to be a manifestation of the nuclear membrane surface area increasing, folding in on itself, causing a groove or a coffee bean. If you cut the groove or a coffee bean in a certain way, it might look like an indentation or a cup. If you cut the indentation or a cup in a certain way, it might look like a pseudo-inclusion, right? So here, this is an invagination or an intussusception of that cytoplasm into the nucleus. Remember, true pseudo-inclusions, you should be able to walk from the cytoplasm, which is pink, to the outer nuclear membrane, which is very blue, to the chromatin, to the inner nuclear membrane, and then to that inclusion, which is the same consistency, quality, color, etc., as the cytoplasm. Those are the things that I want to see to make a pseudo-inclusion. It's usually 1 per nucleus. It's usually present in scattered cells rather than every single cell. This is compared to a pseudo-inclusion, right, or kind of a fake pseudo-inclusion. These don't have those features. They don't have good inner borders because there's no actual nuclear membrane. They have these pale kind of bluish or whitish centers because there's not actually cytoplasm in there. It's just an artifactual vacuole. Often there's more than 1 per nucleus, as you can see here, and often they're in like every single cell. This is thought to be an artifact of fixation or of some kind of physiologic process like inflammation or fibrosis. So remember, anything from freezing to decal to poor fixation to overheating can result in poor processing. These 3 images were taken from the same nodule. On the left, totally benign and bland looking. On the right, very concerning for PTC. So just remember to put all of the features in context and evaluate the non-lesional thyroid tissue for what normal looks like. Because if your normal looks abnormal, then maybe your tumor abnormal is also not so bad, if that makes sense. Here's an example of a consult case we had where the block was processed at the outside, but we have an H&E stain from the outside and an H&E stain from the inside. So on the left, someone might call this papillary carcinoma or even a NIFT-P because they might interpret these as inclusions. We stained it here, totally dark, round, bland, nothing. So now we can call this benign. To me, this is like fascinating, just how where your stain happens can totally change your diagnosis in thyroid. So beware. Okay. Other pitfalls in papillary include the fact that some PTCs can be completely hyalinized or ossified, such that there's only rare carcinoma cells at the periphery. So we had a case just the other day of a really, really sclerotic nodule that really stood out from the background. And on higher power, we saw cancer cells at the periphery. Nice inclusion here, a lot of grooves and wrinkling. So just be mindful, be respectful of these hyalinized nodules. Just look for cancer in or around them because sometimes you will find it. Questions? All right, we will talk about the variants of papillary carcinoma. Remember, microcarcinoma is a size variant, meaning less than or equal to 1 centimeter. This is not architecture, so don't call these micropapillary, right? What are micropapillae? Micropapillae are small papillae. This is not small papillae, this is a small cancer, okay? So papillary thyroid microcarcinoma, not micropapillary thyroid carcinoma. We'll talk about the so-called follicular variant in the context of NIFT-P and then some others. So follicular variant, tumor formerly known as PTC follicular variant. So there were 2 types. One was the infiltrative PTC follicular variant that of course was infiltrative, had follicles and papillae, but predominantly follicles. Then there was the well-circumscribed PTC follicular variant that had only follicles, that had no invasion, but had these funny, cleared, grooved nuclei, okay? The old concept was that the infiltrated follicular variant compared to the circumscribed / encapsulated follicular variant, it was found that the infiltrated follicular variant had BRAF mutations and lymph node metastases, just like classic PTC. And it was found that the circumscribed or encapsulated follicular variant had RAS mutations and really only hematogenous metastases if it had any capsular or vascular invasion, just like, right? Follicular adenoma, follicular carcinoma. So this is now becoming a little bit fishy. Why are these all being called papillary? So the Endocrine Path Society in 2016 renamed the circumscribed encapsulated non-invasive PTC follicular variant to non-invasive follicular thyroid tumor with papillary-like nuclear features, or NIFT-P. If something that was otherwise called a NIFT-P would have had capsular or vascular invasion, it would then be called the invasive encapsulated follicular variant of papillary thyroid carcinoma. I find this a little bit confusing, so I'm going to try to simplify it. As a reminder, these are the proposed diagnostic criteria for NIFT-P that came out in 16 and were revised in 18, meaning encapsulation or clear demarcation, follicular growth pattern with essentially no papillae, no psammoma bodies, small percentage of insular or trabecular growth, nuclear scoring system that met, present or sufficient quantity and quality of nuclear atypia, no invasion, of course, no necrosis or high mitoses, certainly lack of BRAF V600E mutation, okay? Come to me with questions if you have them, otherwise the diagnostic criteria are here for you. So if you remember going back to this old concept, the way I like to think about it, rather than NIFT-P and invasive encapsulated follicular variant of papillary, I think the genetics are somewhat more important than just those nuclear features, right? The genetics and the behavior. So I think of NIFT-P as essentially a follicular adenoma with cytologic atypia, and the so-called invasive encapsulated follicular variant of PTC is essentially follicular carcinoma with nuclear atypia. And I know that not everybody in the world agrees with me, but there is a group of reasonable pathologists who are like, look, this is biologically follicular carcinoma or follicular adenoma. Like, it's become obvious now that we know so much about the genetics. So this is my kind of more easy way to conceptualize these tumors, and clinically more meaningful. Make sense? Okay.
Yes.
Cool. So I know we spent a lot of time on that, but I think it's an important concept to get through. Other important variants of PTC are those tall cell and columnar cell. Tall cell I think of as being very eosinophilic, and columnar cell being very sort of basophilic or blue on low power. Tall cell has these long so-called tram track follicles or papillae with cells that are 2 to 3 times tall as wide, tend to be BRAF mutated, tend to be present in older males with aggressive behavior. Columnar cell almost looks like, to me looks like, what's the word I'm looking for? Endometrial carcinoma, with these sub or supranuclear vacuoles with elongated nuclei, which are very blue. Sometimes the nuclear features of PTC are not even very obvious, but if these are present in an infiltrative form, they can be also very aggressive. So tall cell is not the same as columnar cell morphologically, even though the names are kind of oddly similar. Other variants we might see are oncocytic, which is kind of self-explanatory, Warthin-like, which is basically oncocytic with lymphoplasmacytic stroma. Often we see this in the context of, I bet you can guess, Hashimoto's, just because there's a lot of lymphoid infiltration in the background. There's also hobnail variant, where the nuclei are apically oriented. This is also thought to be an aggressive variant. Diffuse sclerosing and cribriform morular are the two that have what? Squamous morules, right? So diffuse sclerosing tends to have diffuse, at least diffuse involvement of both lobes, if not by tumor, at least by psammoma bodies. It tends to happen in young kind of teenage females with extensive lymph node metastases, and is thought to really be prognostically okay, especially because they treat these patients quite aggressively with radioactive iodine. So questionable worse prognosis, but probably okay. Cribriform morular we know because of its association with FAP. Sometimes these patients have germline APC mutations, but you can get cribriform morular variants in a non-FAP patient. What it looks like are these Swiss cheesy, kind of almost adenoid cystic-like cribriform spaces with, squamous morules. So when you see that, you might want to do a beta-catenin stain. These should have beta-catenin localized to the nucleus. This does not mean the patient has FAP. This means the patient should be screened for FAP because this could be either a germline or a somatic process, if that makes sense. Other variants of PTC include solid or spindled, which again are kind of exactly what they say they are, growing in solid sheets or growing in much more spindled morphology.
This is a quick question, Dr. Cipriani. With the more aggressive subtypes we talked about, columnar and tall cell, how do you find that the ENT surgeons will change their approach? I mean, they don't usually know the subtype when they're going in for the resection, but if you report it as a columnar cell, are they more likely to go back and do neck dissections or?
No. So the treatment of PTC or the treatment of thyroid cancer is essentially preoperative lymph node mapping. So if it's a known cancer on FNA, they'll map the lymph nodes. They'll only really take the lymph nodes if they are radiographically or clinically abnormal. So they won't necessarily go back if they're not radiographically or clinically abnormal with this kind of diagnosis. But with an aggressive diagnosis, what might happen now is in the ball game of the endocrinologists. So they will probably give radioactive iodine.
So the nodes that they take, that's predetermined, and they already know that they were going to take those nodes regardless of the histology.
Correct.
Okay.
So unlike salivary gland tumors, where if you call something high grade, they actually probably will go back and do a neck dissection because of potentially clinically occult metastases. It's thought that doing neck dissections in high grade salivary is useful, but it is not thought that doing prophylactic neck dissections in high risk thyroid cancers is useful. So not done. Exactly. Sometimes these patients pop up with neck nodes like in a couple months, then they'll go back.
Okay. And then the last question I had are any of these particular histologic variants, are they known to cause discrepancies or confusion on FNA, or once you've got the cytology, you're not going to mistake it for anything other than PTC?
So tall cell is pretty obviously PTC because the nuclei are very robustly papillary. They've got lots of inclusions, very dense cytoplasm. Columnar can be tough because the nuclei aren't as obviously PTC. They're elongated. They've got funny features, but they're not, so this might come out as like a follicular neoplasm. So I would say columnar cell might be the more challenging one.
Okay.
It's also much more rare.
I was going to say that's unfortunate considering the aggressive behavior.
Right. But these are the things we deal with. The other variants, generally, the nuclei are satisfactory enough. Psammoma bodies are abundant. So yeah, those are usually fine. All right, other questions on papillary? I hope you don't mind if I go a little bit over 9 o'clock, but we started a little bit late, so I'm just going to keep going. Whoever can stay, can stay. Moving on to follicular. So again, we'll talk more about gross next month, but worrisome features on gross exam for follicular might be a solitary dominant, thickly encapsulated nodule, or a nodule that appears very solid, white, firm, dense on gross exam, perhaps with irregular borders, perhaps with necrosis. What I recommend doing in these cases is something like a representative complete cross-section plus multiple sections of the interface of the periphery/capsule with normal, anything that looks like an irregular border, and of course we may go back for more. Histologic variants are less numerous than PTC, but they still exist. Of course, to diagnose FTC, we need capsular and/or vascular invasion. So here's an example of things, again, that you might see grossly, being a thick capsule, being a weird little satellite nodule outside the main nodule, which could be evidence of some kind of capsular, vascular, or intrathyroidal invasion. Again, you may see a weird undulating border. If it starts to look like a, I don't know, amoeba, like any amoeboid shapes in a thyroid nodule, not happy. So unless it's a very clean, well circumscribed thing, again, anything with a funny shape, I would be concerned with. You will want to submit, here's kind of my diagram of what your sections might look like, where you have nodule, capsule, normal, nodule, capsule, normal, multiple sections of these in a cassette. We can always go back for the rest of the capsule in the case like the top right if we need to. Diagrammatically, capsular and vascular invasion in follicular carcinoma has been nicely presented by the CAP in the cancer protocols, where anything that sort of percolates into the capsule really shouldn't be called capsular invasion. It has to be completely through the capsule. Sometimes you can see a secondary little cap or capsule on the invasive focus, completely outside the capsule. So this is all considered capsular invasion. Vascular invasion has also been somewhat controversial. Most people agree that if you have a tumor nodule inside of a vessel that is either endothelialized or not endothelialized, that has some kind of fibrosis or adherence to the wall or associated platelet fibrin thrombi, this is true this is true vascular invasion. Anything that's an endothelialized tumor nodule that's either bulging into the vessel or detached in the vessel is thought to perhaps be not vascular invasion. Because if you think about it, some nodules are highly vascularized and sort of bulge, right? Bulge into the lumen. If it bulges into the lumen and you cut across it, kind of like a pseudo-inclusion in a nucleus, right? You might just get this detached endothelialized nodule that doesn't show any sign of endothelial injury. So we are looking for signs of endothelial injury being clotting, right, or thrombosis, I should say, fibrosis, etc. Fragmented tumor cells in a vessel without any biologic evidence of endothelial injury is also not considered vascular invasion. So just keep these diagrams in mind when we are looking at invasion in follicular carcinomas. Tumors that have only capsular invasion, such as this characteristic mushrooming through the capsule, are thought to behave very indolently and probably will only get washed with observation. Again, capsular invasion only, the satellite nodule on the other side of the capsule. However, once you have angioinvasion or vascular invasion in a follicular carcinoma, these are thought to behave more aggressively and the patient probably will get treated with completion thyroidectomy and radioactive iodine. So things to be careful for. We note the number of foci of vascular invasion because it's also thought to be prognostically important. I will just remind you here that lymphatic invasion and vascular invasion are separate in the cancer protocols. So we really want to be sure that something is either in a small lymphatic vessel, usually that's going to be papillary, or a large blood vessel, usually that's going to be follicular. Okay, here's what true versus pseudovascular invasion again might look like on an H&E slide. So here's that bulging, right? Here's that bulging into the lumen where the tumor nodule is lined by endothelium, but it still is sort of connected with the base of the rest of this tumor. Here's an example of a tumor nodule that's bulging into the lumen, but now it's got this pink fibrin thrombus with some associated inflammatory cells and blood cells. Sometimes those of you who've signed out with me, we've thrown like a CD61 platelet immunostain to try and sometimes associate platelet clumps with these foci. Sometimes we're successful, sometimes we are not. Questions on follicular? Okay. So moving into our poorly diff, which is more aggressive than either papillary or follicular, as I said before, can arise from papillary or follicular, is defined by solid growth with mitoses or necrosis. This usually sort of looks like thyroid follicular cells. It certainly stains like thyroid follicular cells, this has an intermediate survival between like PTC, FTC, and anaplastic, so years to decades. The Turin criteria outlined the diagnosis of poorly diff, which formerly in the textbooks was called insular carcinoma. So if you read insular carcinoma, currently this is poorly diff. It should have solid trabecular or insular growth pattern with the absence of papillary thyroid carcinoma nuclei, because remember, you can still have solid variant of papillary carcinoma that may be somewhat more aggressive, but probably still not as bad as poorly diff, all right? So no PTC-like nuclei. And the presence of at least convoluted nuclei, I'll show you what those look like, increased mitoses, meaning 3 or more per 10, that's it, just 3 or more per 10, and or necrosis. Who, for extra credit, who knows what this thing is on the right?
That's the Shroud of Turin, which is a
Possibly Jesus.
Yes.
So,
The ghost of Jesus. Okay, so here's what poorly diff looks like. On low power, it's usually very solid or cellular. So when I see something on the slide that's super blue, I get worried, right? I always start to worry when I see solid growth in thyroid neoplasms because it could be verging on poorly diff. In this case, we see nice little nested invasion out into the normal with lots of fibrosis. We see solid growth here with mitoses circled, and we see this punctate necrosis. Remember, the necrosis should occur not in the context of a biopsy site, right? So no fibrosis, no hemosiderin, no cholesterol, no histiocytes, right? This is just pure tumor necrosis, right? Not caused by an FNA. Here's another example of very, very solid with on higher power, mitosis, 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 right? So this is poorly diff. The nuclei don't really look like PTC. They kind of look like more FTC or follicular nuclei, right? They're round, they're regular, they have fine chromatin, no clearing. So this is okay for poorly diff. And this is for comparison what convoluted look like. It's quite subtle, but if you put convoluted right next to not convoluted, I think you can start to appreciate the differences. So the convoluted start to look small, wrinkled, sort of raisinoid, dark. The non-convoluted are still more open, fine chromatin. So this is probably the least feature that I use to make this diagnosis. I more use mitosis with solid growth and necrosis with solid growth. Okay? Okay. The worst thyroid cancer is, of course, undifferentiated or anaplastic. Now this no longer looks like thyroid. It starts to look spindled, epithelioid, or even squamous. These can be basically squamous cell carcinomas. These can look super pleomorphic, tons of mitoses and necrosis. If they're gonna retain anything, they're gonna retain keratin and Pax8. They tend to lose TTF1. They certainly lose thyroglobulin. If they have arisen from a pre-existing papillary or follicular, they should still retain the BRAF or the RAS or whatever is there, but they probably will have gained something like a TERT promoter mutation, etc. These patients survive really only a few months. These are very, very aggressive cancers. Here's an example of a classic anaplastic. Again, that just looks pleomorphic, ugly, high-grade carcinoma. You can't tell this is thyroid. But if you throw a Pax8 on it, you might be lucky because 70–80% of them still retain Pax8. Again, if you throw a BRAF on it and it's positive, you know it came from a papillary. Questions? Okay. Medullary is a small percent of all thyroid malignancies. Only a quarter of medullaries are heritable, so syndromic, right, with Rett germline mutations. The majority of cases are still sporadic. The sporadic ones are generally unifocal in older patients. The familial cases tend to be multifocal, tend to be in younger patients. Depending on the particular mutation, the age range can change. Regardless of whether they're germline or sporadic, they all have Rett mutations, right? So finding a Rett mutation in a medullary doesn't tell you that it's a syndrome, just tells you that the mutation is in the tumor. So these patients generally are tested in their germline to see if there is an underlying syndrome. Because of the calcitonin that's secreted by the tumor, these patients have symptoms like diarrhea, flushing. MTCs can have both lymph node as well as distant metastases. They tend to be located in the upper to middle lobes, which are where the C cells deposit from their embryologic journey. Just based on the growth, I can't really tell whether this is papillary or medullary, but it's certainly a solid white tumor. It can, on histology, be somewhat circumscribed, so don't let that fool you, but it's obviously a mass-forming lesion in the thyroid. It has this stroma, it has high cellularity. The high cellularity is usually nests and cords of cells with very granular purple cytoplasm, right, because this is a neuroendocrine neoplasm, kind of stippled salt and peppery chromatin, so characteristic neuroendocrine type cell morphology for medullary. Don't forget this material that's deposited in the background is
Amyloid?
Amyloid. And what is the protein that makes this amyloid?
It's calcitonin.
It's calcitonin, exactly. So it's not AAAL. It's nothing that we normally see in other amyloids. This is actually calcitonin protein. But because it organizes in the way structurally that amyloid does, it still is Congo red positive, it still is apple green birefringent. So sometimes you see it, sometimes you don't. If you do, great, we'll do the stain. If not, it's okay. It's still medullary. Okay. When we see a medullary, we will inevitably want to look for the presence of C-cell hyperplasia. It can be difficult to diagnose C-cell hyperplasia in the same lobe as the tumor because it probably just overtook it, but you should look for it in the contralateral lobe because it may indicate that the patient has a syndrome. If you see it on H&E, as seen here, great, you can do a calcitonin immunostain to confirm. If you don't see it on H&E, I would argue we can throw a calcitonin on a medullary cancer case to see if there's anything. C-cell hyperplasia can be completely unrelated to a syndrome or to medullary. You can see it in the setting of hyperparathyroidism, aging, so it's really not specific in all cases, except if it starts to form small nodules or little small kind of neoplasms that are precursors to, potential precursors to familial medullary. How do you define C-cell hyperplasia? There are a number of definitions, including 50 C cells per low power field, clusters of greater than 20, greater than 6 or 4 per cluster. So I tend to just use, all right, 50 per low power field. It's quite easy to get there once you have an appropriate immunostain. Questions? All right, the other two tumors I will mention that are very rare birds, like the monk parakeet in Hyde Park these days, are settle and castle. These are both tumors with thymus-like differentiation. Settle kind of looks like synovial sarc biphasic with epithelial and spindle. Castle is basically a carcinoma with thymus-like differentiation. It's basically thymic carcinoma. It has CD5 positivity. It just happens in the thyroid. These are extraordinarily rare. Just as a reminder, clinical implication of a cancer diagnosis in the thyroid. So the American Thyroid Association has come up with a risk stratification system that is so-called low risk and so-called high risk. So any low risk carcinoma is treated with at least hemithyroidectomy and clinical observation. Any high risk carcinoma is probably treated with a total thyroidectomy and likely radioactive iodine ablation. As I said before, lymph node dissection is only done for patients who have known or suspicious lymph nodes, not done prophylactically. Risk factors include things like size of tumor, presence of extrathyroidal extension, number and size of lymph nodes, presence of extranodal extension, presence of things like BRAF mutation. So this is why we report in detail and are very careful about all of these things, because the more you have, the more you're going to push the patient to radioactive iodine ablation. The only reason for a patient to undergo a total thyroidectomy is if they're going to need radioiodine ablation, right? So it's kind of a two-step process. It's not just they have cancer, do a total. It's they have cancer, do they need radioiodine because of their risk factors? If yes, we need to get rid of the remaining thyroid so that it doesn't sink up all the iodine, right? We want the iodine to kill the circulating or the microscopic cancer cells. We don't want the iodine to just go into the normal non-neoplastic thyroid and not do anything to the tumor cells that are circulating. Does that make sense? Okay. That's the end of thyroid. Tell me whether you want me to continue to parathyroid, stop, answer questions.
How much parathyroid do you have?
Not a ton. I can do it quickly if that will help.
Let's just do it then.
Okay. So just as a reminder, normal parathyroid is about half fat, half glands. Chief cells, oncocytes, and clear cells are the 3 cell types you'll see. I should say normal weight is about 20 to 40 milligrams and about half glandular cells, like I said. This will become important. Just to remember, parathyroid disease can either be primary, usually a single gland adenoma, or secondary, usually in the setting of chronic renal disease and electrolyte abnormalities. Usually this is all 4 glands. Parathyroids are removed to get rid of that hyperfunction. There's no way to treat hyperparathyroidism really that's primary except to remove it. If secondary hyperparathyroidism gets so bad, you can also take all those glands out. These are clinical, not histologic diagnoses. As a reminder, surgeons know if an abnormal gland is removed intraoperatively by decrease in intraoperative PTH level, sometimes by sending us a frozen section. Usually the frozen section purpose is just to identify the parathyroid tissue rather than saying whether it's normal or abnormal. However, sometimes some surgeons do ask, is it hypercellular? So we try the best that we can. Abnormal parathyroid morphology, whether it's adenoma or hyperplasia, I think is very overlapping. If you have a picture perfect adenoma, it will look like this, where there's a normal cellular rim and then a monotonous single cell type hypercellular nodule in the background of normal. This is a very rare finding. Usually we don't get such quite beautiful adenomas. Therefore, if it's enlarged by weight, if it's hypercellular on histology, I will just call it an enlarged hypercellular parathyroid gland because the histologic features of adenoma and hyperplasia are overlapping and the diagnosis is more clinical than histologic. That is my bottom line on parathyroid. Some institutions do oil red O stains for fat just to determine that an abnormal gland has very little fat. It's thought that the amount of fat is inversely proportional to functional activity, right? So more fat, less function, less fat, more function. We don't do this, most institutions don't, but it's out there. Remember, for any fat stain, whether it be in parathyroid or in like sebaceous carcinoma, this has to be done on frozen tissue. Once it's fixed, the formalin washes the fat out. So if you ever want to do an oil red O, or we can do it, Ryan can do it in our lab, but it has to be frozen tissue, not fixed.
Is there a special way to freeze it, or you just throw it in a container and put it in the -80?
In OCT, because you're going to have to cut it to cut, you know. So just freeze it like you're freezing a frozen section.
Okay.
Mm-hmm. Exactly. Here's an example of the various morphologies of oncocytic solid parathyroid tissue, more chief cell to clear cell parathyroid lesion, and then as I showed you before, sometimes this microcystic degeneration. So the morphology of these parathyroids can be very variable. Once you're beyond just all right, this is enlarged and hypercellular, what are some worrisome features for parathyroid carcinoma? Because it's rare, but it exists, and I think a couple of you have seen some cases this year. So we start with just increased fibrosis. So if you see something like increased fibrous bands with maybe solid sheets of tumor, this could be called an atypical adenoma. This is treated just like any parathyroid neoplasm with local resection and clinical observation and serologic survey. Once you start to think about carcinoma, to the surgeon, it should be surgically adherent, like stuck to the thyroid, stuck to the muscle. It should destructively invade adjacent soft tissues like thyroid or muscle. It should have vascular invasion or perineural entrapment. It often has these coarse nuclei with coarse chromatin, prominent nucleoli, mitoses, right? Once you start seeing mitoses, once you start seeing necrosis, these are all features of parathyroid carcinoma, but differentiation between atypical adenoma and carcinoma can sometimes be challenging. But the good thing is these are all still treated with local resection and observation. So there's no chemo, there's nothing for parathyroid disease, it's just surgery. So I tend to not be so hypercritical about the differences here, but just note that it's atypical, suggest carcinoma if it looks like it could be, or if it's obviously entrapping a nerve or obviously in a vessel. These are definitive features that you can call cancer. Otherwise, if it just has some sheet-like growth with mitoses, you may suggest, again, atypia. Okay, does that make sense? So invasion, or metastasis, of course. Parathyromatoses is one of these rare diseases that can kind of mimic parathyroid carcinoma. It's an overgrowth of multiple small hyperfunctional nodules of parathyroid tissue. It kind of looks like, on low power, like a recurrent pleomorphic adenoma, right? It's got these little multiple nodules just kind of in tissue. This tends to really only happen after previous parathyroid surgery, where it's thought that the parathyroid tissue seeded the neck and sort of spread and kind of regrew in these little tiny nodules. This can occur in the setting of a previous parathyroid adenoma. It can occur in the setting of, primary or secondary hyperparathyroidism. But again, this is also just treated with local resection and observation. So remember that parathyromatoses is a disease. Remember that it clinically and histologically can resemble parathyroid carcinoma. So just use your other features to help you. Oh, one thing I will mention that I don't have a slide on here, I don't think, is parafibromin. So parathyroid carcinomas are often associated with CDC73 mutation and therefore loss of the parafibromin protein on immunohistochemistry. Can you see my little typing?
Yeah, we see.
Cool. So Mayo has a parafibromin immunostain that sometimes we send these atypical adenomas or carcinomas for. Loss of parafibromin is worrisome. So loss of parafibromin is indicative of a CDC73 mutation, which may be cancer, may not be cancer, still isn't diagnostic of cancer, but it certainly raises the bar. So think about parafibromin. We can talk more about that if we have a case. All right. Oop, no, I don't want more text. Where are my drawings? Mouse. Okay. So yeah, so that was parathyroid. I have very few diagnoses of parathyroid. I either have, this is a little fragment of normal parathyroid. This is a fragment of kind of variably cellular parathyroid. And this is an obviously enlarged hypercellular parathyroid that is lesional. Of course, atypical adenoma and carcinoma can come into your diagnostic repertoire if you need them. But for all parathyroids, most importantly, just give the weight. If you get parathyroid at the time of frozen, even if it's tiny, please try to weigh it because weight is the most important indicator of abnormality. Clinically, they always read the weights. If we don't give it to them, they start to get angry. I put this chart here on immunohistochemical review of follicular cells, C cells, and parathyroid cells, because sometimes the immunostaining can be overlapping, as you can see specifically for things like PAX8, which can stain para C cells and follicular cells. But things like TTF1 should be completely negative in parathyroid. Things like GATA3 should be positive in parathyroid, of questionable positivity in the other types of cells. Just as a reminder, when you may or may not need immunostains to differentiate between the types of cells that we're seeing. Does anybody have more questions or comments?
No further offhand.